Welcome to the show, where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Today we have a special sponsored episode by the Academy of Continued Healthcare Learning with two leaders in obesity and dysglycemia care. Dr. Donna Ryan is Professor Emerita at Pennington Biomedical in Baton Rouge, Louisiana. Dr. Robert Kushner is Professor of Medicine and Medicine Education at Northwestern University Feinberg School of Medicine and Director of the Center for Lifestyle Medicine in Chicago, Illinois. I'm excited to have this discussion about the challenges with weight loss in patients with dysglycemia and type 2 diabetes. Donna and Robert, welcome to the show.
Thanks for having me.
Thank you, Kevin. Happy to be here.
So before we start, I'm just going to ask you to briefly share your stories and journeys to where you are today. Donna, why don't you go first?
Okay, so I am a person who worked for many years in clinical research in obesity. So I have always had a passion for good weight management as a pathway to better chronic disease management. And so I spent a lot of time talking to primary care physicians about trying to encourage them to embrace weight management.
Great. And Robert, briefly share your story and journey to where you are today.
Yeah, Kevin, I fell into this very haphazardly when I was a medical student. I did an elective in nutrition because I wanted to get to the West Coast. I live in Chicago. And it was literally life-changing. The 6-week elective in Davis, California, changed my entire direction of my career because I really thought diet and lifestyle was the most important thing to maintain health. And everything I did since that time, internship, residency, fellowship, has all been towards helping people get as healthy as they can be with a kind of a sub-focus in weight management, because early on 1980s, that really jumped out at me as one of the biggest threats to individuals' health is the weight gain that they have as they age.
Wonderful. And let's get right into it. We're going to talk about the challenges with weight loss in patients with dysglycemia and type 2 diabetes. Donna, I'm going to ask you the first question. Can you please describe the clinical inertia that exists with weight loss management in patients with dysglycemia?
We all see a lot of patients with type 2 diabetes. It's 14% of the population with diabetes. It's huge. You know, in the VA system, 40% of the patients have type 2 diabetes. So we see it all the time. But we have this clinical inertia, I believe, for a couple of reasons. One reason is that, you know, we've all been taught this chronic disease model for type 2 diabetes. What that means is that we don't have to treat it all at once. We need to treat it over a period of time. We need to keep the patients coming back. But I think what that does is it makes us a little complacent. And we also are complacent about trying to achieve normoglycemia. You know, so our goal, our ADA sanctioned standard of care goal for glycemia is a hemoglobin A1C less than 7. Well, that's a laudable goal. Only about 50% of our patients are making that goal. But still, I think what it does is it doesn't capture that, you know, normal glycemia is not less than 6.5. We make the diagnosis of diabetes at a hemoglobin A1C of 6.5. We call pre-diabetes 5.7 to 6.5. But look, that dysglycemia period, that pre-diabetes period, there is an increased risk for all of the cardiovascular and microvascular complications of diabetes. So it's not really pre-anything. We need to be aiming for normal glycemia.
And Robert, what percentage of patients with dysglycemia would benefit from treatment intensification, for instance, to also manage obesity?
That's a good question, Kevin. About 85% or so of adults with type 2 diabetes have coexistent obesity or excess body weight. In fact, it's the weight that drives the increased incidence and prevalence of diabetes that we're seeing in our country. So overall, 85% would benefit from weight loss, but even the additional 15% would benefit from intensification of lifestyle, eating healthy, being more physically active, getting good night's sleep, dealing with stress, and so forth. So we are now thinking about diabesity. We're kind of reimagining this whole dual epidemic of obesity and diabetes and combining it into diobesity. And I really envision over the near future that as we start, this paradigm shift goes on, that individuals who come in and see their clinician with diabetes and are overweight are going to have this dual focus, this dual target treated. And it's not just getting the blood sugar under control that Donna just talked about, it's also getting body weight under control as two targets of treatment.
Donna, you mentioned earlier about the importance of overcoming clinical inertia. How do we go about doing that?
I was just at the American Diabetes Association meeting. And so for a long time, we've talked about weight-centric diabetes management. But this is the first time that I actually felt among the people who were at the ADA meeting that they were really interested in using weight management as a pathway to better diabetes management. We can do better. We can do better in our glycemic management. We can do better in our management of blood pressure, of lipids, of all the complications that are associated with obesity. And the pathway to do that is through weight management. We're finally getting some tools that work, that help patients lose weight and keep it off. Heretofore, it has been difficult with lifestyle change alone to achieve sufficient weight loss to really have an impact on all of those health risk factors. But now we're getting some better medications, better diabetes medications, better weight management medications that help us help our patients to better health through better weight management.
And Robert, what challenges do clinicians face with addressing weight loss in patients with dysglycemia?
Karen, I think the biggest challenge they face is insufficient education in the skill set in order to manage weight. I think any clinician can see a patient who comes in the office and see they're overweight. It's visually apparent, or you can do a body mass index and so forth. So it's not diagnosing and recognizing that someone's overweight. The challenge is, what do you do about it? And that gets back to training and education. We are trying to get more education in medical schools and residency programs as time goes on. And once I think clinicians are educated, they do a better job. The other thing I want to mention, though, is excess weight or obesity really is unique among medical problems. I think very few clinicians have a challenge of bringing up the problem of diabetes with their patients, or hypertension, or sleep apnea, and so forth. But the art of bringing up and having a sensitive, empathetic conversation about weight is not as easy. Weight is very personal. There's a lot of connotations and shame and stigmatization, quite frankly, about it. So in addition to the education, I think clinicians need to learn how to communicate in a very sensitive manner. And that's a challenge, but they can do it with a little bit more coaching.
So Robert, take us to the exam room and give us a case study, story, or an example that kind of illustrates what you just said.
A common example is a patient makes an appointment with their provider. Could be talking about diabetes, but they also been struggling with their weight. The patient is often hesitant to bring it up because of fear that they're going to be chastised, or there's going to be a paternalistic, "I told you so," or "what's wrong with you," or a sense of self-blame. There's often this legacy effect, like, I have seen 10 providers and they always blame me, therefore I'm not even going to bring it up. On the clinician side, they may not know how to bring it up, or they don't want to embarrass the patient. Or if they talk about obesity, do you use the word obesity? Do you say excess weight? Do you say weight gain? Do you say fat? Or if they put it on a problem list, they're afraid the patient is going to be concerned that obesity appears on a problem list and they're going to take fault with it. So there's all this silent dynamic dancing going around. And you know what ends up? It's not even discussed in the office. So we need to train clinicians on how to bring the topic up in a sensitive way, such as, is this a good time to talk about your weight? To show respect and to ask permission to do so.
And Donna, Back to clinical inertia. What strategies do you employ in your practice to overcome clinical inertia with weight loss treatment in patients with dysglycemia and type 2 diabetes?
Well, it is a sensitive subject for patients. So I think the focus in the conversation with the patient is about health. Because if I start the conversation about weight, I'm judging that patient for their body size. So I think the emphasis has to be on health. The single best thing you could do to improve your health would be to make some changes that could result in some moderate weight loss. And you would maybe need fewer blood pressure medicines, diabetes medicines, things like that. Will you work with me to make some changes to your medications and to your lifestyle? So I think going at it, the inertia is not just there on the physician, the prescriber's part, it's also there on the patient's part. So I think you have to go to where the patient is, not start where you are, but start where the patient is. I think we can all do better at prescribing with weight centricity in mind. We really need to avoid those sulfonylureas, which drive weight gain. And of course, insulin is a huge growth factor. We need to avoid insulin whenever we can. The TZDs improve the metabolic profile, but they also cause weight gain. So often, a year or two after your TZD's been prescribed, you're heavier and you've got all your metabolic complications back. So we need to do better with our prescribing and know the profile of the medications and their weight effects. And that's not just true for diabetes medicines. It's also true for the antidepressants, many of which drive weight gain. And it's even true for contraceptive medications, for example. We need to not produce iatrogenic weight gain whenever possible.
And Robert, what can care teams do better to overcome the clinical inertia?
Yeah, Kevin, so we've been talking about challenges and clinical inertia thus far. And one thing we haven't talked about is our system of practice, which is set up for acute care visits. It's very difficult for a clinician, him or herself, to manage a chronic care problem in an acute care system. So that's where these chronic care models come in. And part of a chronic care model is working within a team, not only team within your office, but also extended to the community. So when we talk about improving weight management and dysglycemia, it's helpful to think about who else should be invited on the team to help this patient. Those would be, as an example, registered dietitians to help with medical nutrition therapy. It could be potential health psychologists to deal with coping and stress-related issues. It could be a physical therapist or a personal trainer that you would refer out to, as well as advanced practice providers, such as a nurse practitioner, a physician assistant, or a nurse in the office. All of these individuals are a team that can provide all the needs of a patient who's dealing with a chronic care problem, such as being overweight and dysglycemia.
And just to follow up on that, Robert, what are some of the obstacles that prevent more of these teams from existing?
The biggest obstacle is our healthcare system is not set up in an acute care visit, which is usually 10 to 15 minutes. Dietitians are often not reimbursed. Physical therapists and personal trainers are rarely reimbursed. And we often don't have the resources and protocols readily available to us in the office to help patients with what they need when they leave the office, right? Because we have to think, even though we only have 10 to 20 minutes with them, they go home in their own environment, their own home, to manage this chronic problem. So the more resources we can provide and the more team approach we can offer, I think the more successful they're going to be.
All right, let's move on in terms of talking about the treatment options that are available for patients with both obesity and dysglycemia. Donna, I want to address that question to you.
Yeah, that's great. I really want to endorse what Bob said about it taking a team and the multiple approaches that can really help patients. A couple of things he didn't mention are bariatric surgery. So for patients with a BMI of 35 or higher who have diabetes, especially if it's not being well controlled, bariatric surgery is an option. And about 50% of patients will no longer have type 2 diabetes after their Roux-en-Y gastric bypass. It's a little less with the gastric sleeve, but that's still a great option for patients. It our thinking about obesity has always been that it's a chronic disease, but we're learning if we can get enough weight loss, we can actually put patients with diabetes into remission. That is normal glycemia on no diabetes medications. So that's one important thing. Another thing he didn't really mention was commercial programs. So we're fortunate in that we have some commercial programs that do have a good evidence base around them. So for delivering lifestyle intervention, we've got Weight Watchers, Jenny Craig, Nutrisystem, all of which have published their results. There's also some published results around Noon. These are great commercial lifestyle options for patients. And so I think that the problem is so large. I think we really cannot handle all of this in our healthcare system. We need the private sector to step up and help us. Unfortunately, patients really have to navigate that private sector because they're often exposed to treatment approaches that don't work, have no evidence base behind them, and are potentially unsafe. So if it sounds too good to be true, it probably is. And that's why we need to be advising our patients on which of the commercial options are really the best ones.
Now, Donna, to follow up, for the patients listening to this episode, how can they better evaluate those private sector options? What kind of tips can you offer them?
I think the ones that are the tried and true ones, the ones that have been around a long time, like such as WW, the new name for Weight Watchers, it has the greatest consumer satisfaction, both on the basis of efficacy and value. The treatments that are suggesting their efficacy with a before and after picture, avoid those. It's losing weight is hard work, and it's not as simple as taking a before and after picture. I think you want to make sure that the commercial program has an advisory board of competent clinicians and scientists, and that the treatments are evidence-based. And with a little research, patients can find those things on the internet.
So when it comes to lifestyle interventions, Robert, what is the efficacy of weight loss with these lifestyle interventions alone?
Well, Kevin, I could tell you, if you take all the studies that have been published, the average weight loss after about 1 year ranges between 5 to 8% from where you started. Now, that could be a little misleading because that's an average. And I'll tell you, any patient who walks into a room doesn't think of themselves as average. I think I'm the one who's going to do the best. And we have to take that into consideration. There's a great deal of heterogeneity with any treatment, lifestyle included. Some gain weight with a lifestyle treatment. Some are losing much more body weight. By an average, it's about 5 to 8%. So there's a lot of reasons for that. It could be the genetic makeup, the biology of what is going on with that patient, how intense the lifestyle treatment is. We know the more intense the delivery, not only in frequency, but also guidance and the adherence to those changes, the more successful they'll be. And then culture and access and affordability, all these social determinants of health. Probably one of the biggest concerns, though, in addition to that, is the difficulty sustaining the weight loss. And that's where treatments like Donna was talking about, pharmacotherapy or bariatric surgery, becomes very important. Almost all the studies published, again, looking at average, if you lose 5 to 8% in the first year, or even 15%, someone that does very well, if you follow those group of individuals up over time, there's a slow weight regain. And that's because of the biological forces that causes one to regain weight, as well as the fatigue that probably sets in with changing lifestyles. So very important. Lifestyle is foundational to health and to chronic disease management, like individuals with dysglycemia and who are struggling with their weight, but often need more intensive treatment for long-term success.
And Donna, I'm going to ask you now about those pharmacological options, and I understand there are dual GIP and GLP-1 agonists under investigation. Can you tell us more about these and how you think they will fit into the current treatment paradigms?
The big news in management of diabetes and weight management is these biologic approaches. We're finally doing much better in our understanding of the biology of glycemic regulation and the biology of body weight regulation. And it's really these better biologic understandings that has given us some great medicines. So we have the GLP-1 receptor agonists. They've been around about 15 years, and they're getting better in producing even more glycemic control and robust weight loss. The same thing is true for the SGLT2 inhibitors. We're lucky to have them because they also produce more moderate weight loss, but still some pretty good weight loss. But the biggest news that's happening in diabetes is this combination of a GIP GLP-1 molecule that affects both the GIP and the GLP-1 receptor. And that is producing, on average, in patients with diabetes, about 13% weight loss at 1 year. In obesity, they released their results, and 22% weight loss in patients with obesity. It's not approved for obesity yet. That'll take about 2 years to work through the regulatory process. But meanwhile, we have this drug that's quite efficacious for weight loss in persons with type 2 diabetes. There's also more powerful GLP-1 receptor agonists. For example, semaglutide. It produces on average almost 10% weight loss in persons with type 2 diabetes. So great drugs, and the pipeline for what's coming is getting better. You know, Kevin, I think one of the big reasons that we have not been more weight-centric in managing diabetes is we haven't had a way in our primary care practices to help people lose weight and keep it off. And we're finally getting there with these drugs. So I think that it's going to really have an enormous change in the management of diabetes, in the prevention of diabetes, and in the prevention and management of all the complications that occur with obesity. I'm hopeful.
So Donna, to follow up, tell me who the ideal patient would be. I'm a primary care internal medicine physician. Tell me the ideal patient that I would consider prescribing some of these medications to.
Yeah, well, for the patients with type 2 diabetes, it's exactly like, we have guidelines for more robust glycemic targeting. So we want patients who are not older. We want younger patients. We want patients earlier in their course of their disease. We want patients who don't have a lot of complications. We want patients who are motivated and willing to undertake a more intensive weight loss effort. So I think it is possible to select those patients and offer this treatment to them. These medications don't work as well on their own. They do produce some weight loss, but if we really want to get the benefits of these medications, we need to be prescribing them with lifestyle advice around diet and physical activity. So among your diabetes patients, those who are younger, those who are motivated to undertake lifestyle change, those who haven't had diabetes for 25 years, who are earlier in the course of the disease, this sort of approach can really have dramatic improvements in glycemia, hypertension, dyslipidemia, lots of the complications that go along with type 2 diabetes. So that's really the patient profile we want to find. I think it's more difficult for patients who are in their 70s and up to lose weight. It is possible to do it safely, but we always are more cautious in older people because we're more concerned about the loss of lean mass in addition to that fat mass. Of course, what we're trying to do here is reduce fat mass, especially that ectopic abnormal fat that's really driving the dysmetabolic syndrome.
So Robert, can you tell us about the exciting assessment tool and CME activity that both you and Donna developed together?
Kevin, we created this clinical inertia assessment tool to help clinicians assess how effective they are in achieving short and long-term therapeutic goals for patients with type 2 diabetes. Clinicians can gauge their skills in addressing dysglycemia and obesity and see how they measure up to their peers. This tool also provides additional resources and education based on individual needs. We recommend participating in the CME activity available after completing this tool. In this CME activity, Dr. Ryan will offer a how-to method for introducing strategies into practice.
And this tool is available in the show notes. It's also available at achlcme.org/T2D-management. You're listening to a special sponsored episode by the Academy of Continued Healthcare Learning with two leaders in obesity and dysglycemia care. We are excited to interview Drs. Donna Ryan and Robert Kushner. Now I'm going to ask each of you your take-home messages to the Kevin MD audience. Donna, why don't you go first?
Okay, my take-home message is I think you need to aim for 10% weight loss or 15% weight loss. It is not necessary for patients to achieve a BMI of 25 or even 30 or even 35 to get a lot of health benefits with weight loss. The physiology of weight loss is such that no matter what your starting BMI, the loss of 10% or 15% can really result in dramatic improvements in glycemia, in blood pressure, in lipids, in inflammatory markers, and a lot of health improvements. Patients will feel better and they will have a lot better metabolic profile. So you don't need to aim for an ideal weight. 10% or 15% should be your goal.
And Robert, what are some of your take-home messages to the Kevin MD audience?
Kevin, my take-home message is that we are facing a dual epidemic in this country of both obesity and diabetes, and we combine them into one word called diabesity. We want to tackle both of them simultaneously. The challenge on the provider side is knowing how to do it effectively and successfully in a very short office practice. Most clinicians are already out of training, so it's really incumbent upon them as an adult learner to educate themselves through CME, through podcasts like this one, and through articles to increase their skill set and competency to treat both obesity and diabetes, and to learn the communication skills needed so they can partner with their patient in a supportive, empathetic manner.
And once again, the CME activity and tool from Drs. Ryan and Kushner is available in the show notes and at achlcme.org/T2D-management. Donna and Robert, thank you so much for sharing your time and insight. Thanks again for being on the show.
Thank you, Kevin.
Thank you, Kevin. I enjoyed it.